students, welcome to the platform of eGurukul and Dr. Bhatia Medical Coaching Institute. I am Dr. Ramyasree, your OBGYN Guru. So I am doing the FMGE PYQ series, so let us see the next video. So let's start from the question which we have left in the previous video. A pregnant lady delivered child. 24 hours later, she came with heavy vaginal bleeding. What might be the cause? So after she has delivered, 24 hours later, she came with bleeding. So this is secondary PPH. Primary PPH is bleeding from delivery up to 24 hours. Secondary PPH is bleeding after 24 hours and up to 12 weeks. So this is secondary PPH. What can cause secondary PPH here? Circumvallate placenta is more prone for causing antepartum hemorrhage. Filamentous also mainly causes antepartum hemorrhage. Battledore does not present you with secondary PPH, but substantiate lobe can present you with secondary PPH. Substantiate lobe mein you have one cotyledon separate from the entire placenta but interconnected. But if this cotyledon is left inside, it can always lead to secondary PPH, right? What is the most common symptom of endometriosis? So the symptoms of endometriosis, you can remember it as dance, India, dance. Symptoms of endometriosis, you can remember it as dance, India, dance. So you have dysmenorrhea, infertility, and dyspareunia. So you have dysmenorrhea, infertility, and dyspareunia. And what is the main symptom of endometriosis? So the main symptom of endometriosis is dysmenorrhea, right? So as I told you, it is mainly dance, India, dance, dysmenorrhea, dyspareunia, infertility. So this dysmenorrhea is also described as progressive or triple dysmenorrhea. That is, the pain will be present throughout, and pain is the predominant symptom, guys. What is endometriosis? Endometriosis is presence of functioning endometrium outside the uterus. So endometriosis is presence of functioning endometrium outside the uterus. Okay. A female is in labor, is having occipito-posterior position. Cervix is fully dilated, forceps applied in OP position, direction, and tried to rotate. Which type of pelvis head cannot rotate? Gynecoid is a circular pelvis, platypaloid is transversely oval, anthropoid is anthroposteriorly oval. Usually android and anthropoid mainly favor the occipito-posterior position. Android and anthropoid favors the OP position, right? So here this is, and anthropoid may it favors OP position and favors face to pubis instead of rotation. Anthropoid may, as there is no space, you cannot rotate it. So it is anthropoid where you can have head fails to rotate. Okay. So gynecoid is the most common pelvis, whereas platypaloid is the least common type of pelvis. We also have android and anthropoid. Android and anthropoid are little like best friends. Android is the worst pelvis among all these pelvis. So gynecoid is round, android is heart-shaped or triangular, anthropoid is anteroposteriorly oval. Platypaloid is also called flat pelvis and it is transversely oval. Side walls are straight for everyone, but it is convergent for android. Ischial spines are prominent in android. Anthropoid also, it can be plus or minus prominent. Sacrum is deep and curved in gynecoid, whereas it is slightly curved in android, anthropoid, and platypaloid, right? Subpubic arch is wide in everyone except android and anthropoid, right? Android favors OP position as well as deep transverse arrest, whereas anthropoid favors OP position or occipito-anterior position, and it favors face to pubis delivery. Platypaloid favors face presentation. Platypaloid favors face presentation. A patient on 4th day postpartum presents with fever more than 100 degrees Fahrenheit for 24 hours. Dysuria and foul-smelling lochia. What is the diagnosis? So whenever you have fever post-delivery and persisting for more than 24 hours, you can call puerperial pyrexia. There are multiple reasons for this puerperial pyrexia, but one of the most important reasons for this puerperial pyrexia is Foul smelling lochia, so it is mainly endometritis. So infection of the genital organs is called as puerperal sepsis. So you can go with the option of A, right? So normally in the puerperal pyrexia, day 1 to day 2, you'll have UTI. Day 2 to day 3, it is endometritis. Day 4 to day 5, it is wound infection. Day 5 to day 6, it is septic pelvic thrombophlebitis. And day 7 to day 21, it will be mastitis. Now, this paper was little difficult paper in the FMGE PYQs. If you observe, topics are like puerperium, and this is hysteroscopy. A patient underwent hysteroscopic procedure for septal resection. Procedure took more than expected time. Patient went into unconscious state. What might be the underlying cause? So whenever you are doing hysteroscopy, there is one risk that you are going to push the fluid, and there's also fluid coming out. But if you push excess fluid compared to what fluid has come out, then this fluid can go and cause fluid volume overload and pulmonary edema, even hyponatremia, hyperammonia. So here, this mainly looks like in terms of fluid overload. So hysteroscopy is an instrument which is used to visualize inside the uterine cavity. So you're going to push some fluid and you're going to just push fluid and let the fluid come out also. The basic fact is that I want to inflate the uterus and keep the uterus inflated. So as I'm pushing the fluid and the fluid is coming out, so we have the fluid, how much fluid is going inside and how much fluid which is coming outside. So that we are going to check with the, we have to always keep track. If the fluid going inside is more and the fluid coming outside is less, so then we call it as fluid deficit. And that can lead to volume overload in the body and pulmonary edema. So you have two types of fluid. When you are using monopolar cautery, as it conducts electricity, when you are using monopolar cautery, as it conducts electricity, you have to use glycine, sorbitol. Whenever you're using bipolar cautery or diagnostic, then we go for, so when you're using bipolar cautery or for diagnostic, then we go for the normal saline, ringer lactate. So when you're using normal saline and ringer lactate, stop procedure at fluid deficit of 2 to 2.5 liters. 2 to 2.5 liters. Get alert at 750 ml fluid deficit. Similarly, when you're using monopolar cautery, stop the procedure when fluid deficit is 1 to 1.5 liters. Get alerted at 750 ml fluid deficit. So just what I want you to understand is whenever you're using hysteroscopy, there is risk of volume overload and pulmonary edema. Okay? What is a drug which is given in the management of endometriosis? So oxytocin, GnRH, methotrexate. So we give continuous GnRH or GnRH agonist. Indeed, GnRH agonists or GnRH analogs are the drug of choice for the management of endometriosis. So in management of endometriosis, the medical management of endometriosis, you have drugs which create a state. See, endometriosis, the endometrial tissue is growing because of the estrogen. So I have to give some drugs which will stop the growth of the endometrium, right? So we have pseudomenopause drugs. When there is a menopausal state, endometrium won't grow. So pseudomenopausal drugs we have GnRH analogs, which can be both agonists as well as antagonists. And we have danazol, gestrinol. We also have pseudo-pregnancy drugs. This progesterone will suppress the growth of the endometrium. So you can give any progestogens, or you can give combined oral contraceptive pills or mifepristone. The first line drug in the management of endometriosis is the progestogens, whereas the drug of choice is GnRH analogs. In GnRH analogs also, we have a newer GnRH antagonist, which is an oral GnRH antagonist, which is mainly used as a drug of choice as per American College of Obstetrics and Gynecology, and the name of that is elagolix. Okay. Okay, what is this image? So, here we are ligating the anterior division of internal iliac. Here we are ligating the anterior division of internal iliac. So, this anterior division of internal iliac is mainly done in PPH. So, first you always try to ligate the uterine artery at isthmus. That didn't help. Then you ligate the ovarian artery. That also didn't help. Then you ligate the anterior division of internal iliac artery. Then you ligate the anterior division of internal iliac artery. So here this is you go from the bifurcation of common iliac, you have to go 3 to 5 centimeters below. And then you ligate the anterior division of internal iliac. Okay. A 54-year-old female with amenorrhea from last 16 months, what should be the hormone levels? So how do we diagnose menopause is this question. How do we diagnose the menopause is the question. So menopause is mainly diagnosed by increased LH and FSH levels. So in menopause, estrogen and progesterone levels drop down. So as estrogen and progesterone levels drop down, there is no negative feedback. So as there is no negative feedback, FSH and LH levels will be very high. So high FSH and high LH. So increased FSH and LH. So there will be cessation of menstruation. There will be appearance of menopausal symptoms like hot flushes on 2 occasions 1 month apart. Vaginal cytology will show 100-0-0, that is parabasal and basal cells will be 100. Intermediate and superficial cells will be 0 and 0. Serum estradiol levels will be less than 20 picogram per ml and FSH and LH will be more than 40. This is how we diagnose the menopause. So these were some of your PYQ questions. Another video will be posted. So you have a totally 4 videos. Watch all the 4 videos to cover maximum MCQs. Thank you so much, guys. See you in the next video. Thank you.